when you're looking to improve. So what are your goals of joint preserving surgery? Well, let's improve the quality of life of our patients, maybe hopefully delay or prevent the onset of arthritis, and hopefully minimize any impact on future hip surgery in terms of complications related to your surgery, the bony anatomy as you've corrected, and not compromising subsequent reconstructive surgery, and the type and placement of your internal fixation, again, to make sure that your next surgery is not a problem. And when we try to define the quality of medical care, you have to look at the Don Dino and then look at the 6 pillars that defines the quality of medical care. And when we look at introducing or learning any surgical techniques, these are the 6 criteria we need to form the basis of analyzing and comparing our outcome. So we have to look at the acceptability of what we're doing. Is it accessible to the vast majority of our population? How appropriate is that medical treatment we're providing? Is it safe to the patient? How effective is it? And the efficiency, i.e. the recovery from those outcomes. And all with this, you have to have key performance indicators to assess each variable, and by that way you're able to determine if what you're providing to the patient has value not only to the patient but also to the medical care system, which again addresses to some aspect the aspect of funding and reimbursement in North America. As surgeons, we'll have to learn and introduce skills throughout our career in order to improve care, the demands of our professional environment, but we need to control it to limit the patient risk. Yet the perils of the learning curve are inescapable, no less in practice than in residency. And that's Atul Gawande who brought those terms. And we have to recognize this, and that helps us provide the best care to our patients. And I think when we think about the learning curve or education in joint preserving surgery, you have to look at where you're coming from. An arthroscopist will have a very different learning curve than a joint-specific surgeon when considering the integration of hip arthroscopy. So a guy that does hip replacement says, I'd like to do hip scopes, will have a very different learning curve than a guy that does shoulder arthroscopy and decides to do hip arthroscopy. So we have to be able to recognize that when we define our learning program. And we have to identify the possible consequences of these technique or approach in terms of surgical time, patient clinical outcome, and complications. And when you look at the learning curve, actually the steeper the learning curve, the better it is for your patient, because you're minimizing that time where exposure to greater risk or complication is minimized. And how do you get that learning curve shorter and also minimize the downside to the patient is where the rate of the presence of preceptor is critical. And I think this will come in nicely in terms of the different fellowships that are offered in hip preserving surgery. But those are the type of things we need to keep in mind, again, as professionals and also looking out for our patients. If I just kind of briefly talk about my own experience in terms of acquiring the skills for hip preservation surgery, which were non-present during my residency in the 1990s, I did a 1-year fellowship with Joel Matta, which was mainly PAOs, and then subsequently got introduced to various aspects that were evolving at the time: surgical dislocation with Joel Matta, Jeff Mass, and Reinhold Gantz, combined arthroscopy and mini open or Huta with Philippe Joden and then Ribas, and then the pure arthroscopy techniques with Mark Philippon and Chris Larson. But these were all through personal visits and through meetings at the time when the field was evolving. But still, I think that type of approach, when you're learning new skills, I think is still valid today to maintain the proficiency and minimize complications. So what's available now? Well, you have the Isha and Smith-Nephew International Hip Arthroscopy Targeting Fellowship. It's considered of 3 main parts. Part 1, which is done in your respective area or country where you learn basic and intermediate skills of hip arthroscopy with someone in your area that is an expert, an ISHA member. Then 4 weeks prior to the ISHA meeting, you embark on an international visit, visiting 2 or 3 centers. And then you're presenting at the annual ISHA meeting a brief report as well as a formal podium presentation talking about your experience. You have to be a member of ISHA for a minimum of 2 years. You have to have a completed orthopedic residency program and be either board eligible or something equivalent within your country. You need to have some knowledge in arthroscopy with an interest in hip arthroscopy, be able to speak English in order to present, and be able to be away 2 months from your clinical practice to do this. The deadline is every year, December 15th, around that time. And most of the years we have about 2 individuals that are going through this experience, which has been ongoing since 2015. So a very good experience. The other one is the William H. Harris Career Development Award in Hip Preservation, which is co-sponsored by Washington University and the Anchor Group. It's a 3-month visit looking at 3 to 4 anchor sites over 1 consecutive year. Consists of clinical observation, surgical observation, and mentor category training. We encourage the individual to involve in the clinical research program. Usually we have 1 awardee per year. The deadline this year, January 15 of 2017. And have access to the anchor sites based in North America, mainly Canada and the US. And the director of that program is John Colisi, which you can contact by email or by mailing. So those are the key 2 hip preservation fellowship programs that are available, and they both provide very insightful information, and I think I would strongly encourage all of you who want to learn to do this as well. So finally, to minimize the learning curve, you have these fellowship, but there's also what we call, and I think we should start introducing, which was talked about by Frye and colleagues, the Procedural and Autonomy and Supervision System, or PASS. And it uses a scale to break down a trainee's progression to operative autonomy into 4 stages: show and tell, active help, passive help, and supervision only. And these were well established, lined up in JAMA last year. I think those are type of programs we should institute in order to, especially in hip preservation surgery. So in conclusion, I think we have to all remember surgery is more than just fixing things. As surgeons interact with patients and a team of clinicians to make shared decisions, we have to make sure that we're assessing both technical and non-technical skills in treating our patient. And we should approach any techniques for implants in a stepwise approach to better understand what are the potential benefits and downside. Thank you. Merci.